Good afternoon and welcome to the Technical Assistance Network for Children's Behavioral Health, Cultural and Linguistic Competence Learning Community webinar series. Our webinar series focuses on promoting health equity and eliminating disparities in child, youth, and young adult behavioral health. Topics are generated by you, individuals working in or being served by behavioral health organizations, and partnering with systems of care, states, communities, tribes, and territories. The TA Network, as it is known, is the National Training and Technical Assistance Center for Children's Behavioral Health for the Substance Abuse and Mental Health Services Administration. I am Selena Webster-Bass, CEO of the Voices Institute and core partner of the CLC Technical Assistance Team. Today's webinar is titled, Moving Forward, Using the National CLAS Standards to Address Social Justice and Health Equity. This webinar will focus on understanding the history of the CLAS standards and learning how they can be used to advance health equity and social justice by improving access and effectiveness. Today's webinar will be led by Catalina Booth. Catalina is the Executive Director of the Center for Community Learning in Miami, Florida. The Center for Community Learning is focused on providing training, technical assistance, research, and program evaluation on issues affecting diverse and traditionally underserved communities. As a partner in the TA Network, Center for Community Learning provides technical assistance in the area of cultural and linguistic competence. Their expertise focuses on issues of language access, CLAS standard implementation, community capacity building, diversity and equity training, behavioral health literacy, and reducing behavioral health disparities. In her role as a member of the TA Network, Catalina has focused her work on CLAS standard implementation, designing materials to educate administrators, practitioners, and consumers regarding the history and purpose of the CLAS standards, as well as how to implement the CLAS standards at all levels of the organization. She has conducted extensive training and technical assistance on culture and cultural identity and how to implement the CLAS standards. Prior to joining the Center for Community Learning, Catalina was an in-house attorney for a major attorney. In that capacity, she did everything from taking cases to trial to creating legal compliance programs and conducting training for employees at various levels of the corporation. This presentation is being recorded. Your lines will be muted right now to help eliminate the background noise, so feel free to use the chat box to type in any questions or comments during the presentation. Following our presentation, we'll open the lines for further questions and discussion. When the presentation ends, please stay on the line to complete a brief survey. In addition, we will be hosting roundtable cultural and linguistic competence and behavioral health equity office hours tomorrow at 2 p.m. The office hours tomorrow will be an opportunity for you to ask additional questions and seek more in-depth answers to your implementation questions. The roundtable office hours will be staffed by members of the CLC team at the TA Network, as well as CLC practitioners from systems of care with extensive experience in CLAS standard implementation. So without any further ado, let's get started. Catalina?
Thank you. Thank you for that introduction. I normally don't add the part about my prior life as a trial attorney, but in this case, because we are delving into the Civil Rights Act and some of the regulations that come from it, I thought it would be helpful for you all to know my background when I turn into a law nerd. Hopefully I'll keep it to a minimum because our hope is to make this presentation very applicable so that you can implement what you learned today. And as you can see from our learning objectives slide, our goal today is not to teach you everything there is to know about the CLAS standards. We have a series of webinars that are recorded on our YouTube channel, and hopefully Tiara can post those on the chat line. And we have a series of webinars that went into the history of the CLAS standards and then in-depth implementation examples for each of the themes. So if you are needing an in-depth look and training into the CLAS standards, we recommend those to you. And we will also send out that link to all the participants afterwards. Today, we want to take a fresh look at the background and purpose of the CLAS standards so that we can use the CLAS standards as a tool to reduce disparities and improve health equity. We have found in our work, as we provide technical assistance on this subject, that many organizations get stuck when they treat CLAS standards as an administrative policy requirement. In contrast, we see that when organizations focus on the substantive purpose of the CLAS standards, they are successfully able to make progress towards reducing disparities. Therefore, we wanted to provide you an opportunity to refocus your CLAS implementation efforts by looking at the history and the basis of the CLAS standards. So for today, we have 4 learning objectives. First is to review the purpose and history of the national standards for culturally and linguistically appropriate services, known as the CLAS standards. 2, to recognize how the CLAS standards relate to Title VI of the Civil Rights Act. Number 3, apply a new lens to the CLAS standards to understand how they are designed to address social justice and health equity. And 4, explore practical ways to implement the CLAS standards to address social justice, improve health equity, and reduce disparities. And in reference to number 4, we will do so by giving you several community examples, practical implementation examples from several communities around the country. A quick review on what the CLAS standards are. The National CLAS standards are a set of guidelines issued by the U.S. Department of Health and Human Services. Their objective is to improve healthcare quality and advance health equity by establishing a framework for organizations to serve the nation's increasingly diverse communities. The National CLAS standards are a comprehensive series of 15 guidelines that inform, guide, and facilitate practices related to culturally and linguistically appropriate health services. The purpose of the CLAS standards is noted in the slide. As you can see, the purpose of the CLAS standards is they are intended to advance health equity, improve quality, and help eliminate healthcare disparities by providing a blueprint for individuals and health and healthcare organizations to implement culturally and linguistically appropriate services. Now I wanted to pause here and make this a little interactive and get a sense from the group using the public chat box what you think the definition of health disparities is, or health equity, either one. And I'll give everyone a minute to put that in the chat box. So your definition or an example of health equity or health disparity. And people are typing, so I'm going to give everyone a little bit of time. Okay, we have one answer is differences in health based on a number of systemic factors as a definition for health disparities. That's very good. Another response was not having access to health care. Yes, that is a form of a health disparity. These are great answers. I'm going to wait about 30 seconds more because people are typing, and then I'll continue forward. I always like to know where people are starting from or what their preconceptions are so that we can all end up on the same. Health disparity is a negative difference in the outcome of a service compared to their counterparts. Excellent, Daryl. Indeed, Healthy People 2020 report by the U.S. Department of Health and Human Services Advisory Committee on National Health Promotion and Disease Prevention defines health disparity as a particular type of health difference that is closely linked with social, economic, and or environmental disadvantage. Health disparities adversely affect groups of people who have systemically experienced greater obstacles to health based on their racial or ethnic group, religion, socioeconomic status, gender, age, mental health, cognitive, sensory, or physical disability, sexual orientation or gender identity, geographic location, or other characteristics historically linked to discrimination or exclusion. So as some of you noted in the chat, what's important to note in this comprehensive definition of health disparities is the mention and the focus on social determinants of health and how those affect outcomes and lead to disparities in outcomes. And it's quite a broad range of factors that are included in this definition. And some more definitions of health disparity that I think are excellent examples of a disparity is not having insurance for all mental health needs. And that is one form of disparity. The interesting factor is a lot of these studies have found that even given differences in health insurance, the social controlling for those differences still leads to disparities, meaning that it's not just the lack of insurance is one barrier, but the barriers go beyond that. And another definition on the chat box is when health is impacted in a particular racial group based on environment, discrimination, and access. Very good definition. I think that sums up all of those words that I read to you all. Health equity. The definition of health equity, according to the Robert Wood Johnson Foundation, and let me stop here before I read the definition. The Robert Wood Johnson Foundation website is an excellent resource for everything there is to know about health equity and ways to improve health equity. So I highly recommend that you visit that website. And according to the Robert Wood Johnson Foundation, their working definition of health equity is that it means that everyone has a fair and just opportunity to be healthy. This requires removing obstacles to health, such as poverty, discrimination, and their consequences, including powerlessness and a lack of access to good jobs with fair pay, quality education, housing, safe environment, and health care. For the purposes of measurement, health equity means reducing and ultimately eliminating disparities in health and its determinants that adversely affect excluded or marginalized groups. And put another way, the Office of Minority Health of the Department of Health and Human Services says that health equity is the attainment of the highest level of health for all people. I went through those definitions because sometimes we read the purpose of the CLAS standards and those are just words. But when we look at the actual definitions and the meaning and the literature behind what those words mean, it shows us that the CLAS standards are a powerful tool designed specifically to address issues of discrimination, disparities, and social determinants of health. We just have to view it that way and use them that way. And that's what our hope today is, that by looking at the background and how they came to be, we'll be able to do that in our organizations moving forward. The CLAS standards, as most of you know who are familiar with them, begin with one principal standard, which states that the purpose of the CLAS standards is to provide effective, equitable, understandable, and respectful quality care and services that are responsive to diverse cultural health beliefs and practices, preferred languages, health literacy, and other communication needs. The remaining 14 standards are organized by themes. The first theme is governance, leadership, and workforce development, and those are standards 2 through 4, communication and language assistance, which is standards 5 through 8, and continuous quality improvement and accountability, standards 9 through 15. And I want to lead a movement to change that last section to also include engagement, because there's a lot of good methods and ways to improve engagement mentioned in that last theme of the CLAS standards. So what we're here for today. So we've reviewed the CLAS standards, and with that review under our belt, we can focus on the history of the CLAS standards, from their civil rights roots to their current use as a health equity roadmap. It's important to look back at the history and the influences that helped shape CLAS standards, because that history can help shape and guide our implementation. The development of the national CLAS standards can be seen as part of a larger national call to action to address disparities that are experienced by culturally diverse groups. The timeline we're about to look at highlights some of the federal laws and policies that were enacted in the latter half of the 20th century. And when you see this timeline from the beginning to the end, you will see that the CLAS standards fit squarely into the civil rights, their roots in the Civil Rights Act of 1964, which began a discussion and then led to developments that really turned the tide and began a movement to focus on the disparities in the well-being of marginalized people. Title VI of the Civil Rights Act of 1964 states that no person shall, on the grounds of race, color, or national origin, be excluded from participation in, be denied the benefits of, or be subject to discrimination under any program or activity receiving federal assistance. Under Title VI, a recipient of federal financial assistance may not take action that is motivated by race, color, or national origin discrimination, including selecting program site location that excludes individuals or denies them benefits, or subjecting individuals to segregation or separate treatment. I'll pause there. That means that anybody, any organization, and that would be, I venture to say, a vast majority of us on this call who receive federal funds, directly or indirectly, would be subject to these requirements. So it's important in a legal sense, and I'm not going to give you legal opinions on what would constitute a violation or what it wouldn't. I'm going to, for today's purposes, we're going to take this as the background and the roots of the CLAS standards so that we can understand how they can be used to create positive change. In addition to obvious direct discrimination, the statute prohibits disparate impacts. Disparate impact discrimination occurs when a recipient has an otherwise neutral policy or practice that has a disproportionate and adverse effect on individuals of a certain race, color, or national origin as compared to individuals of a different race, color, or national origin. A recipient of federal financial assistance is prohibited from utilizing criteria or methods of administration that have the effect, even if unintentional, of subjecting individuals to discrimination because of their race, color, or national origin, or have the effect of defeating or substantially impairing accomplishment of the program's objectives. All of that in practical examples. Courts have found that Title VI violations occurred, disparate impact violations, so this would be what we would call not the direct discrimination, but the disparate impact violations occurred in cases. Some examples would be when an organization has policies or practice that result in the provision of fewer services or benefits or inferior services or benefits to members of a protected group. Some examples of litigation that has concluded violations of Title VI were utilizing a funding formula for distributing federal aid that resulted in a substantially adverse disparate impact on minorities, or the use of a non-validated IQ test that resulted in a proportionate number of African American school children being placed in special education classes as a result of the test. And not only, and one thing important to remember is that the definition of national origin extends to a protection regarding a person's birthplace, ethnicity, ancestry, culture, and related national origin, or their ability to speak English. So discrimination or disparate impacts based on a person's language or cultural background would also be considered a violation of Title VI. So this means that people cannot be subjected to discrimination because English is not their primary language, or because they have customs or background that makes them different from others in terms of their language and cultural customs. So that is a very fast look and non-comprehensive look at Title VI of the Civil Rights Act, because we could talk about that entire courses in law school about that. But what we need to remember is that that was the origin, the basis, what started a chain of events that led to the CLAS standard. And the movement, the civil rights movement, extended to healthcare pretty early on. In 1964, the Medical Committee for Human Rights was created to serve as basically street medics during civil rights protests, but also they called for their own protest discrimination at hospitals and other medical practices. And in 1966, the Medical Committee for Human Rights held its annual convention, and Martin Luther King Jr. was the featured speaker. And he spoke these words to the attendees: "Of all the forms of injustice, inequality in healthcare is the most shocking and inhumane. That statement is the foundation the foundational in health equity movement, and eventually one of the principles that led to the creation of the CLAS standards." Another key development in the call to action was Section 504 of the Rehabilitation Act, which was passed after the Civil Rights Act. Section 504 of the Rehabilitation Act of 1973 prohibits discrimination on the basis of disability, both in the delivery of services or benefits, as well as in employment. And this is an important fact in our work because the protections of Title VI were extended by this act, and the protections created by the statute extend beyond physical impairment and mental impairment to include mental illness as a basis for protection. So here's where we get to the good stuff. You started with a statute and then progressed to statutes. And just so you know, this timeline is a summary. There's other events that occurred that are not highlighted here. I've highlighted the ones that are important to the CLAS standards. And the next development was that finally got the issue of health disparities into the nation's political agenda was the creation of a new academic discipline known as health economics. These new health economic researchers began producing and began seeing data trends that showed dramatic variance in costs, healthcare behaviors, practices, and outcomes. And one of the groundbreaking reports in this field was the Heckler Report. This was a true breakthrough for policy and research of healthcare disparities. Shortly after taking office, U.S. Secretary of Health Heckler organized the Task Force on Black and Minority Health. This was the first convening of a group of health experts by the U.S. government. I want to show you the next slide, sorry. And this was the first convening of a group of health experts by the U.S. government to conduct a comprehensive study of racial and ethnic minority health and to engage the nation in deliberate, thoughtful discussions about the poor health status and needs of racial and ethnic minority communities. The report filled 9 volumes and established a comprehensive picture of racial and ethnic health and healthcare disparities throughout the United States. In her opening letter, Secretary Heckler stated in the report that it was a sad and significant fact that there is a continuing disparity in the burden of death and illness experienced by blacks and other minority Americans as compared with our nation's population as a whole. The report detailed the wide range of health and healthcare areas where significant disparities exist for African Americans and other minorities versus whites, including a 5-year difference in life expectancy and an infant mortality rate for blacks twice that of whites. It estimated 60,000 excess deaths occur among those minority populations annually. And the report included 8 main recommendations that really formed the basis for what would later become the CLAS standards. And they called for outreach, cultural awareness, coordination, healthcare access, and data research. The next part of the development of the call to action that led to the national CLAS standards involved the formation of the Office of Minority Health shortly after the release of the report. The Office of Minority Health was created in 1986 as one of the most significant outcomes of the task force report from the Heckler Report. And the Office of Minority Health is important because it is a part of the U.S. Department of Health and Human Services, and it's dedicated to improving the health of racial and ethnic minority populations through the development of health policies and programs that would help eliminate health disparities. And I urge you, if you haven't already done so, to visit that website. There is actually, when you go to the Office of Minority Health, there's also a sub-web page called Think Cultural Health. And there is a vast number of resources on that website, including some very good training on cultural and linguistic competence for practitioners, not just clinical practitioners, but also those of us that are more on the administrative side or even wraparound coordinators, all levels of practitioners. And so I urge you to go to that website and look for that training. But the Office of Minority Health is important because its mission statement is what led to the CLAS standards. their goal is to develop and promote policies, programs, and practices to achieve health equity, to provide funding for programs, to improve data collection, to foster research and evaluation, and to establish and strengthen the network. So what we have so far is you have a civil rights statute that leads and eventually leads to a report that provides data and an impetus for the formation of a framework and infrastructure at the federal government to address disparities and to address the issues. The next step was when Congress passed the Minority Health and Health Disparities Research and Education Act of 2000. That led to a series of research and the creation of vast amounts of data to back up the fact that there was disparities, ongoing disparities, and we'll take a look at what some of that data shows. During this time period also came the first edition of the CLAS standards in 2000. The Department of Health and Human Services released the original CLAS standards after it released a report called Healthy People 2010. In that report, the report detailed comprehensive nationwide health and promotion and disease prevention agenda, including elimination of health disparities. And one of the action items included the original national CLAS standards. And so that was the start. And that was a start, but the more work needed to be done. And what happened through the passage of the Minority Health and Health Disparities Research Act is that we got more data, more specific data, to show that the problem was not improving and that we needed to somehow address the problem in a different way. And some of the key disparities research in this time frame of 2001 to 2005 are listed on this key disparities research page. But I want to bring your attention to the two that are highlighted on this one. The first one is a document called the Surgeon General's Report, Mental Health, Cultural, Race, and Ethnicity. There was a supplement to that one. It was called the Supplement to Mental Health, a report of the Surgeon General, and it was released in this time period, and it documented the existence of striking disparities for minorities in mental health services and the underlying knowledge base. Racial and ethnic minorities, the data showed in this report that racial and ethnic minorities have less access to mental health service than do whites. They are less likely to receive needed care, and when they do receive care, it's more likely to be poor in quality. And the report stated that disparities had powerful significance for minority groups and for society as a whole. A major finding of the supplement is that racial and ethnic minorities bear a greater burden from unmet mental health needs and thus suffer a greater loss to their overall health and productivity. So even though a structure had been put in place, progress hadn't been made, and the data continued to show ongoing disparities. And that was further backed up by the Institute of Medicine's report of unequal treatment confronting racial and ethnic minorities in healthcare. This report basically provided even more evidence that U.S. racial and ethnic minorities are less likely to receive even routine medical procedures and experience a lower quality of health care. And that report was followed up by a Institute of Medicine report called In the Nation's Compelling Interest, which considered, this is when they went from data to saying, okay, now that we have this data, how do we change the tide? How do we make changes to reduce disparities? And In the Nation's Compelling Interest made the case that for the benefits of greater racial and ethnic diversity and identified institutional and policy level mechanisms to garner broad support among health professions, leaders, community members, and other key stakeholders. So we went from the creation of a structure to data to fuel change. So that puts us in the range of 2007. We had all these reports come out, and as a result of these reports, the federal government created the National Partnership for Action to End Health Disparities. And it was a creation, this group was created because despite improvement in overall health and well-being in the United States over the past several decades, disparities continue to exist. So the NPA, National Partnership for Action to End Health Disparities, was created to mobilize a nationwide, comprehensive, community-driven, and sustained approach to combating health disparities and to move the nation towards achieving health equity. Well, that is what started a chain of events that led to the Enhanced National Class Standards. As they began to study the reasons why progress wasn't being made, hold on, I'm going to take a sip of water. Why progress wasn't being made, the group determined that one of the areas that needed to be changed is that we thought of culture too narrowly when we first started this process with the original class standards. And the definition of culture was very limited. And through these focus groups and these studies and these academic studies, they discovered that culture was much broader and that culture needed to incorporate, the class standards needed to define culture in a way that encompassed all the social determinants of health, not just race, but all the different components of social determinants of health and of culture. And that's what they did. They came up with a comprehensive definition of culture that became part of the Enhanced National Class Standards in 2013. And again, when we send you the link, if you want further information on that, we have a webinar that is directly related to understanding that expanded definition of culture and how it affects. Tiara, some folks are having issues with audio, so I'm not sure if you want to address that. I'm not sure if you saw it. But anyway, hopefully most of you can listen in. It's an isolated, but I have found that the best way to access the audio is via the phone line rather than your computer line. So maybe Tiara will post something on how to access that version of the audio. Okay, so we started with the Civil Rights Act, and we've moved through a series of changes and a series of changes that lead us to the Enhanced National Class Standards. What I wanted to point out from this timeline is that you started with a statute, and change started to occur as you added data and research that gave fuel to the argument and gave structure to the methods for reducing disparities. So you started with a statute, then you gave people a way to implement by providing data, and then you led to a framework, a series that would help organizations move their work. Paul, in case y'all can't see it, the audio is better not on the phone line today. I hung up after having problems, good quality on the web app. Okay, there you go. So perhaps today the phone isn't helping any. Okay, so now we come to how the National Class Standards, this is the Enhanced National Class Standards. They can be downloaded as well, but that slide shows all 15 class standards. So how do we move forward? How do the class standards relate to social justice, and how can we use them to address racial injustice? Well, the Enhanced National Class Standards address racial injustice through their explicit focus on eliminating racial and ethnic health disparities across the United States and on advancing health equity, and that is the attainment of the highest level of health for all people. More specifically, according to Think Cultural Health, culturally and linguistically appropriate services are increasingly recognized as effective in improving the quality of care and services. By providing a structure to implement culturally and linguistically appropriate services, the Enhanced National Class Standards will improve an organization's ability to address healthcare disparities. And this relates to the Civil Rights Act, because remember back when we talked about the Civil Rights Act, which prohibited direct discrimination, it also prohibits disparate outcomes. And the class standards directly aim to address disparate disparate outcomes by providing effective, equitable, understandable, and respectful quality of care responses to diverse cultural health beliefs and practices, preferred languages, health literacy, and other communication needs. So by their goal and by their very nature, the Enhanced National CLAS Standards are aimed to address these issues of social justice and health disparities. And the keys that we get from the principal standards are important to realize that it's not, and these are key ways to address disparate outcomes and to lead to health equity. And one is paying attention and incorporating diverse cultural health beliefs and practices, using consumers' preferred languages, paying attention to health literacy and other communication needs. So it's going beyond a simple checklist to actually going into the substance of what of people's individual cultural needs to reduce barriers. And as we get into the implementation examples, we'll see what a difference that approach can make. And how can these tools that we have in the CLAS standards be used in our organizations? What does it look like when an organization takes a social justice, health equity perspective to implementing its programs and policies and procedures? And so with these next examples in these next slides, we're going to see the examples of some communities that have been doing this. And I want to pause here before we dive into them. We use these communities as examples because we have closely worked with both of these communities at the state and local level. They have come to us in the TA network for specific technical assistance in different parts of their programs, and I'll try to highlight some of the places where we've given technical assistance, and they have in turn taken that knowledge and that technical assistance to create substantive change. I say that as a plug to encourage each one of you to go back after this webinar and think of areas that you may need help in implementing the CLAS standards or any aspect of cultural and linguistic competence. And then contact us. We'll have our contact information at the end so that we can set up a call to discuss how we can provide individualized TA. Training and providing information like this is effective, but it's not a substitute for sitting down one-on-one and addressing specific needs that your organization might have. So our first two examples come from Indiana. And when, if you attend the office hours tomorrow, Brenda will be from the state of Indiana. Brenda Graves-Kroom, who's on the webinar today, will be in attendance, and she can help answer some more specific questions about how they've implemented these programs. But I just want to highlight, from my perspective, how their implementation addressed social justice and addressed health equity needs in a unique way. So if you have specific questions, you can put them in the chat box, or you can come tomorrow to your office hours and get them answered by someone from Indiana. So Ford County is a nonprofit community health center serving the communities of North Central Indiana. And Ford County is committed to increasing access to a continuum of care while integrating physical and behavioral health and well-being. Their primary goal is to ensure that the services are rooted in quality and meaningful to their patients and focused on creating a collaborative, client-centered approach. They are located in Logansport, Indiana, and Logansport has experienced one of the fastest-growing immigrant populations in the state, with two groups. First, the Hispanic, Latinx community, and secondly, Burmese immigrants. They've received an influx of immigrants from that country. And so now, as it currently stands, Logansport has one of the highest Hispanic Latinx populations in the state. In the past 2 years, they have changed how they address the substance abuse treatment for the Spanish-speaking consumers. When they started this process, they had one clinician who spoke some Spanish. The description was a little fluent, So she was a little fluent in Spanish, and she conducted the group services. And the issue that they were having was that the material was in English. The group was mostly conducted in English because a majority of the participants spoke English. So they used the language of the majority of the group. And they found that the interactions and interchange of experiences between peers and clinicians was very limited because of the language barrier. And therefore, they found it very hard to determine whether the goals towards recovery were actually being achieved by participants. What they decided to do is to focus on improving the quality of service for Spanish-speaking clients. The way they went about it was by creating appropriate health literacy and support materials in the client's preferred language, and they had on-site interpretation. So they basically went down the CLAS standards to the language assistance and instituted that as a way to address the fact that Spanish-speaking clients were not able to access services, and the outcomes were not the same as other groups. And they successfully, they had great success, and they're now serving more people than in the past, not just because they're getting more referrals from courts and probation, but because they are more equipped to serve a particular segment of the population that was not being appropriately served. And I chose to highlight that because what they did is they saw a need, identified a gap caused by culture, caused by language, and found a way to address it, not just superficially, but a way to actually attack the problem and fix it, and have found that more success and more effective services when doing that. Another example from Indiana is from Elkhart County. The source is their system of care, and this it's a long story, but I'm going to tell it all because I think the step-by-step process that they used was very informative and very effective. They started the whole process with a CLC, a Cultural Linguistic Competence Organizational Self-Assessment between the source or the organization, the partners, so all the service providers. And so in that self-assessment, the goal was to determine where are we in terms of cultural and linguistic competence and where do we want to be. And they learned through that process that they identified disparities and disproportionalities in Elkhart County. So with that data, they created their behavioral health disparities impact statement. And then their next step was to create a CLC committee. And that committee met regularly around the data findings to create a community cultural and linguistic plan that included a CLC policy that was designed to help promote. They focus on education and trainings with partner organizations, service, and programming. So I'll highlight a couple things that you will also see in our next example. One of the key components here is an engagement. And they engaged the community, and they created a structure, which was the CLC community, to make lasting change, to identify those social determinants of health that were creating barriers, to identify structural things that were creating barriers and address them. And they found that their local data, they identified that there were some serious disparities around youth of color who were being detained in detention centers at a much higher rate than their white counterparts. So they did additional research, and they found that youth of color were disciplined more harshly in schools, which created a school-to-prison pipeline where children of color were criminalized more often and more harshly than white children. So they started, like most of us do, with a checklist of things. Okay, I know for my grant I need to do my behavioral disparity impact thing. So I have some data. My next step is cultural and linguistic competence, and then my CLC policy. They got those things checked off, but they went a step beyond that, and they used that data to say, okay, what is the underlying cause? Why do we have more African American youth in detention centers? And they realized what was creating that disparity. And so in their efforts to, these are their words, which I love it, in our efforts to disrupt the pipeline, the source has partnered with the juvenile court system, the county prosecuting attorney, and the Juvenile Detention Alternative Initiative to expand access to mental health supports and services. So in their study, they realized that one of the reasons there was a disparity is because a particular part of the community was not able to access mental health services. So they went into these organizations, into these government agencies, and provided mental health support. And they were able to divert children with mental health challenges away from the juvenile justice system while maintaining child and community safety. Through their juvenile justice project, the source staff conducted mental health assessments with youth whose intake screenings indicated potential mental health concerns. And upon assessment results, staff connected youth to appropriate community-based services and scheduled follow-up assessments for juveniles to track services received and overall progress. And the CLC coordinator for the source began planning jointly with the director of juvenile courts on ways to create a disparity subgroup in the Juvenile Justice Center to focus on reducing the disproportionate number of children of color who have traditionally been detained in the detention center. So here's an organization that in the process of implementing the CLAS standards found some really significant social justice issues and used the tools from the CLAS standards to address that issue and to create change. In the meantime, they were also busy creating change for the Hispanic Latinx community, which was the largest minority population. They found some disparities in the accessing of services and found that community was not accessing. So they made changes, and they found in their CLC plan to collaborate with the marketing team to discuss signage audits. And what this led them to realize was that the signs they had were not culturally responsive to the population of service, so it wasn't very effective. And so the source took its findings to the local community mental health center and informed them and kind of gave them a little bit of information and helped them to understand the need to have Spanish language signage throughout the mental health community center. And so now there are many more Spanish language signs through the building to help the Spanish-speaking consumers navigate it. And they're starting the process to start a Spanish-speaking mental health promotion program for immigrants and Hispanic youth called the Bienvenido program. And the source staff are launching a family survey to understand the experiences of families, particularly families of color with the juvenile justice system. So those are all big and small changes that were founded in the CLAS standards and implementation of CLAS standards, which have led to lasting change and reduction of disparities in these two communities in Indiana. We have a poll question just to kind of shake things up and do something a little different. What CLAS standards do you think Elkhart County applied in the programs that I briefly described to you? And you can pick one of these answers. If you could please vote. A couple more seconds. People are typing. Correct. Those of you, we have 60% of you voted B and D, and that is that CLAS Standard 1. They provided effective, equitable, understandable, and respectful quality care and services that are responsive to diverse cultural health beliefs and practices, and preferred language, health literacy, and other communication needs. And also D, CLAS Standard 13. They partnered with the community to design, implement, and evaluate policies, practices, and services to ensure cultural and linguistic appropriateness. So good job, everyone. We can go back to the slides, please. All right. Our next example comes from Broward County. The system of care there is called One Community Partnership Number 2, and they have a cultural and linguistic competency subcommittee that was tasked with developing and overseeing the CLC plan for the organization. And this plan included implementation of the CLAS standards. And the overarching goal was to ensure a systemic and strategic approach to increasing the cultural responsiveness of services and support, as well as to increase sensitivity and appreciation for diversity and cultural issues. And the CLC committee joined forces with the social marketing committee, and they were tasked together with developing and launching a social marketing campaign and activities. What was remarkable about this combined group was that they had an average of 15 participants at the meetings, at the regular meetings, which represented an average of 5 system of care organizations and 5 youth and 5 family members. So at every meeting at the table were administrators and service providers, but more importantly, there was youth that were being served and family members of the youth being served. And that enabled the CLC committee to truly understand where the needs and the gaps were. On one day, the CLC coordinator and the CLC consultant gave a presentation of the CLAS standards. And after that presentation, the community members that were in attendance began to share with them a variety of different experiences they had been through, in which, not knowing about the CLAS standards or the CLAS standards not being implemented, they suffered health disparities, and they were not able to access services, or the services were ineffective. And they expressed to the CLC committee a desire to create a way to train people, to train consumers in the CLAS standards, to educate them about the rights and the tools that the CLAS standards gives participants and consumers. And they created a series of videos that the scripts were written by them, the content was determined by them with some assistance, but it was truly led by the community members. That was very effective in training people on what implementation of the CLAS standards looks on a practical basis. So this is just some pictures of some of the activities they did. I'm not an expert on this data, but I'm showing it to you with some trepidation since I'm not an expert in it, but I will try to explain it. The following charts depict the change that occurred between enrollment and discharge for national outcome measures. These are measures used by their evaluation team, and they were reported by 125 consumers. And this first chart depicts the percentage of youth with negative scores at the time of enrollment. That's blue, and then red is the time of discharge. And the data is presented to compare all youth to specific subgroups relevant to the project's goal of reducing health outcome disparities. And the data indicated that across all youth, measures with the greatest gains during project participation were improved function in everyday life, improved social outcomes, and improved feelings of overall health. It's noted that across all youth, 9% of youth presenting with high levels of psychological distress at the time of enrollment did not report psychological distress. So key measure after key measure showed that the services were effective. When the data was evaluated by gender, while the sample size was relatively small, it appeared that the subpopulation with the greatest improvement in national outcome measure scores were hopefully I'll get the acronym correctly, SOGI. Sexual orientation, gender identity, and expression. All those with diverse backgrounds in this category had the greatest improvement. One of the reasons was they changed the way they collected data, and they specifically collected data that included not just gender. And that helped them tailor services and create more accurate data picture. Another measure of effectiveness and reduction of disparities was not just an outcome and service. This slide shows, hold on. Okay, so when the data was evaluated by race and Hispanic ethnicity, it appears that a larger percentage of Hispanic youth improved overall health perceptions and social connectedness as compared to all youth, while the differences are found between black, so why were they able to reach these goals? And I see some questions here in comments, and we'll address them in just a minute. So I see them, I will not lose them. So the reasons they were able to address these disparities and improve outcomes for the group was, one, they developed an infrastructure to address disparities. Just as the timeline showed us that the federal government created an infrastructure for addressing disparities, similarly, One Community Partnership 2 created an infrastructure which consisted of a CLC committee that met regularly and included community participants. 2, they've created a process for engagement, and on that committee were community members as well as service providers. And they changed the forms to include collection of SOGI data. So that was the infrastructure that allowed them to even address disparities. And they also collaborated with diverse groups. So let's pause again one more time and do a poll to see what CLAS standards Broward County applied. If you can fill out the poll is live, so feel free to click. And you, once again, everyone is, I'll give it a moment, is correct. They implemented all of, their approach was very wide-ranged, and they started from an organization that advanced and sustained class and health equity through its policies. They provided effective, equitable, and understandable quality of care and services, and they collected and maintained accurate and reliable demographic data as they changed how they collected SOGI data. If we turn back to the slides, I'm going to try to answer Evelyn's question about the tobacco use and binge drinking increase before discharge. We can go back to the...
Catalina, I'm just having some technical difficulties,
okay.
So I would encourage you to go ahead and address Evelyn's question while I get back connected. My apologies.
Yeah, unfortunately I can't without looking at the data. Okay, let me look at it here on my own copy of it. Do that. Give me a second, Evelyn, and I'll get to it. You asked about binge drinking.
Okay, we're back to the presentation. My apologies.
Evelyn, that is what it appears to show. Okay, so yeah, that's a good point, and I will get an answer to that because it does appear to show that. And my guess is that that's something that they're now addressing, because I know that the focus was in some of the other areas of being connected with some of the other measures. So I will get a question, but you're right, on its face it does that. I was hesitant to show this since I'm not an expert, and unfortunately the CLC coordinator had to leave for an appointment for OCP2, so she's not on the line, but I'll get an answer to that. Okay, so we had some comments. Paul Davies had a good point, which was, unfortunately, as with many mental health interventions, substance use and tobacco use was not addressed effectively, and that could account for some of this. And then Naomi, and I agree with this comment. She's gonna. I'll tell you the story of why we featured Elkhart. Two examples from Indiana. We've been. Brenda works at the state level, and she came to us years ago, and we started doing technical assistance. And then she did with this at the state level, and then she has done a phenomenal job of passing that down to the systems of care of Indiana and equipping them to do this kind of work. So she used the opportunity to get technical assistance to then become a resource to the organization. And that's really the same model that has happened in Florida. We've provided individualized technical assistance. We helped Broward County develop an assessment of class standard implementation, and then that enabled them to apply some of these programs. And so, what were some of the keys that Broward County had to addressing the disparities? Was the creation of a CLC committee, engagement and collaboration, and changing their forms, which enabled them to apply a wide variety of class standards. So I think this is perhaps the most important set of slides here at the end, is why it matters. Why does it matter if we look at the class standards with a social justice lens? And why does it matter if we look at it at implementation? Why should we implement the class standards and address health disparities and reduce disparate outcomes? I think it's important to look at the class standards and realize that it's connected to a larger purpose and strategy. It really came out of and was birthed out of the Civil Rights Act, and it is a way to implement, it is a way for organizations to implement the Civil Rights Act and the regulations. And I don't say that to scare people and say you're going to get sued and this is going to happen. I say that to encourage you that it is part of a larger movement, and it is part of the effort to improve civil rights and address social injustice. The next thing of why it matters is that it addresses underlying structural issues that create barriers. As we saw from the examples in Indiana and Florida, when you take this perspective and you identify disparity and you dig deeper and you find the root social cause or social determinant of health that's at play, then that enables you to address the barriers. In this situation, for example, in the situation in Indiana, they dug deep as to why the statistics, and there were so many more black youth in juvenile justice detention centers, and they found there was a lack of access to mental health services. By addressing that disparity and addressing that need, they were able to make change. Similarly, in Broward County, when they found that youth of diverse sexual orientation and gender identity expressions were not accessing services, they began to collect data in a different manner and provide a different array of services to bring those youth into the organization. The other reason that it's important, and that really my personal passion, is that it makes equity and social justice a priority. Sometimes when you listen to class standards webinars and trainings and read the material, it seems like just another checklist, just another grant requirement, and it gets to be a little tedious and monotonous. Okay, there's another grant requirement, I have to do this. And when we look at it, it's not just another grant requirement, but it is a way to make equity and social justice a priority. It provides a framework and some practical ways that you can address those issues. And I think what makes for a little lasting difference is that it addresses root causes, not just create another new program. but it really forces you to look at the root causes of the disparities and address those root causes. The reason it matters in our work specifically is even more than other areas of health and medicine, the mental health field is plagued by disparities in the availability of and access to its services. These disparities are viewed readily through the lenses of racial and cultural diversity, age, and gender. And it matters because individuals with serious mental illnesses die on average up to 25 years earlier than general population. So as if we needed another incentive to dig deep and find root causes, these statistics help. And the bottom line is, and we're going to get to the comments because we have some great comments, is that in order to understand and effectively address barriers to care, use a civil rights lens to implement the CLAS standards. Be a detective and look for those areas where there's disparate outcomes between groups, especially those that are traditionally underserved. Some comments that I think are great for the discussion is, in Indiana, from Brenda, Indiana's Juvenile Detention Alternative Initiative partners, including Indiana System of Care, are addressing racial and ethnic disparities with preventative steps as well, such as training on implicit bias. Yes. And this was really one of the conversations that sparked this webinar, was the conversation on the need to go beyond. We've defined cultural and linguistic competence in a narrow way, and we want to realize that we should really be talking about behavioral health equity, which includes a discussion on social determinants of health, implicit bias, and other deeper and oftentimes more difficult topics. We have some resources here, and you can download the slides, including the resources. It's a variety of resources about implementing the CLAS standards, to talking about the impact of civil rights on healthcare disparities. And this CLAS toolkit is phenomenal. It is, Connecticut put out this CLAS toolkit, and it includes some practical ways of implementing the CLAS standards to address social justice. And this is another tool for implementation. And I think we're going to unmute the lines now and open it up for questions.
So we have a lot of folks on with us, so we're going to encourage everyone to go ahead and post their questions in the public chat.
Okay. Okay, that's good.
All righty.
That's fine. Yeah, you're right. Yeah, and we have a great discussion here, and I will do my best to address it tomorrow on office hours about the differences in effectiveness of tobacco and other substance abuse services. And we had Jean-Michel Bervel had a good point that one of the reasons that they may have seen a data difference in Broward County was from their experience in HIV services. Men disclosed sex only with women on intake to sexual risk reduction services, but at the end they disclosed also having sex with men. So stigma is the real barrier to disclosure. So it's entirely possible that one explanation for the difference in the answers to engaging in binge drinking and tobacco products is that while receiving services, they have either become more aware of their own behaviors, or the stigma was reduced, or they felt more connected and able to reveal those. One question is, how would this work with student health as a student health advisor member to improve meals and activities, including mental health services? Are you talking in the school health services? Yes, okay. Well, there's a variety of different things. That's one idea that we are proposing, and we will have a webinar on this later, probably closer to the summer, is the use of community health workers or promotoras in the school system for the provision of mental health services. In other words, having family members or other community members with lived experiences trained to help facilitate the provision of these services and addressing these services. So that's one practical way. In terms of implementation of CLAS standards on the school level, I will tell you that the good news is that most school districts are already familiar with the CLAS standards because the Department of Education has an initiative in that area. So the next step is putting them into practice. And there's a variety of different ways that can be done at the school level, ranging from how language assistance services are to when services are provided so that they're provided in a more culturally appropriate way. So I would urge you to contact us, and we can answer specific questions and provide you with resources because we have worked with school districts. We have found that one of the primary needs is education to service providers and school administrators regarding the CLAS standards and regarding culture and mental health. Yeah, you're talking about funding between not equal among the districts to change the distribution. You are correct, and there are lawsuits existing out there challenging funding mechanisms and the disparate outcomes they have. So, again, I would love to give legal opinions, but I can't. So if you want offline to ask some questions, there is litigation on that subject. Excellent question from Evelyn Clark. Are you familiar with racial equity theory of change and how this may overlap or differ from CLAS standards? I am not, but I'm going to do homework now. I don't know if any of those. Unfortunately, my coworker, Selena, who might have been able to answer that question, had to leave to pick up kids early because there's a weather emergency in Florida. We still have some questions coming in, so we'll continue to lots of people typing. Yeah, one of the things I love about these webinars are how much I learned from you, and that's something that one of the commenters just posted. That's why I encourage those that want to learn more or have more specific questions or want to get into a deeper dialogue, including perhaps the racial equity theory of change, would be to come to the webinar tomorrow. But more importantly, I'm about to, first thing, yes, you need to do that link, but also I'm not sure if all of you are members or how many of you are members, but we have what's called a cultural and linguistic competency learning community, and it's where we post all our webinars, we provide training classes, and so we urge you to join that because we regularly send out resources, newsletters once a month, and then sometimes emails intermittently, and posted on this learning community page after you register are all our in-depth training on all the topics that we've covered today. Any more questions? Someone's typing, that's why I'm waiting. How do you sign up for the learning community? That link that we posted right here, I posted it, and then the Institute posted it. You can sign up there. Naomi, it's our pleasure to mention Fort County. You have Brenda to thank for that. I sent out an email to several people on holiday, and Brenda was hard at work and answered my questions. So that's how you guys came to be. And you answered her questions. We are always happy to share and love to hear success stories and even challenges that people are facing. So if you have a success story or a challenge you're facing in this area, please, I'm going to put up my contact information. That's me, Catalina Cerna-Booth. Please send us those examples. We'd love to feature them in future learning community webinars or newsletters, because this is a field where we all learn from each other, and everyone does things in a different way. So I highly encourage you to send us your successes and your challenges, either by email or by joining us on office hours tomorrow. I think we have a couple more questions, and I'll give a couple more minutes for questions, and then we can give everybody back some of their valuable time. This last link that you pushed, that was a Qualtrics link. Tiara, I'm not sure if you meant to put that one on there. The question is, I'm interested in how the training for lived experience community would work. Please send me an email with your direct questions, and we'll set up a time to talk, or just join us tomorrow and we can start that conversation. So here is the correct link to the learning community. And one of the things that will be forthcoming, that's coming soon for learning community members, is the University of South Florida and the TA, the CLC group for the TA network have designed a environmental scan, which is looking to see how people are implementing CLC strategies and class standard strategies. So if you are a learning community member, you will be receiving that in the next couple of months. So I urge you to join the link. How do we access CEU information? Jara, what's the latest on that one? She's typing
so CEUs were not offered for this webinar, but we can send everyone who attended a confirmation of attendance email.
Francis, send me an email. I appreciate your desire to help with including consumer-directed approach within class standards. I would love to start that conversation, so please send me an email and we will definitely do that. Can they go ahead and start the survey as we finish up questions, or does that need to be once you close out? Yeah.
Yep, they can, for folks who would like to go ahead and exit now, can go ahead and click on the link for the survey, and folks who stay on with us till the end will receive the link as well.
Okay. Any last minute questions before we start letting everybody go? Once you finish that survey, that's it for today. If there are no more questions, we look forward to continuing the conversation tomorrow. One last time, this link that I'm posting is for the office hours tomorrow. I can cut and paste correctly. So your tasks today, right now, are to complete the survey and then register for the office hours tomorrow and then register for the learning community. You can do that in Thank you, everyone. Look forward to hearing more from everyone once we, in the office hours. And if anybody, one last announcement, if anyone is attending the University of South Florida Conference, Children's Mental Health Conference, and would like and has a need for technical assistance, please email me and I will connect you with Selena Webster-Bass, who will be in attendance. I would love the opportunity to sit down with you and provide technical assistance. We have found that those meetings at conferences often start some very productive dialogue. So we encourage you all to make use of that opportunity if you will be there. And we will have that same opportunity at the University of Maryland Training Institutes, which will be later in the year.